Now let's move on to the third refractory error, the cylindrical refractory error, that is astigmatism. So what is astigmatism? What is the definition of astigmatism? Different refractory power in both principal meridian or axis of eye. Okay? Are we clear about this? Are we? No. We will understand it. Let's first classify it and then we will try to understand it. So we can classify astigmatism into two broad types. Regular astigmatism, irregular astigmatism. Okay? What do you mean by regular astigmatism? When both principal meridian are at 90 degree to each other. Irregular, when both principal meridia are not at 90 degree to each other. Then, I'll explain all this, everybody. Regular astigmatism can be divided into further subtypes with the rule. You may have heard this and they may have been troubling you, everybody, all these names. Against the rule and oblique. With the rule, astigmatism is said to occur when vertical meridian is more curved. Against the rule is said to occur when horizontal meridian is more curved. And oblique astigmatism is when both principal meridia are at 90 degree to each other but not vertical and horizontal. If you understand from the English, it's okay. Otherwise, see, I'm drawing simple diagrams. Okay? Let's try to understand. First of all, I said there is regular astigmatism. What do I mean by meridian? That's the first thing. Meridian means curvature. See, my cornea is curved. Yes, we have already said that our eyeball is aspherical. Because our eyeball is aspherical, I can say the vertical curvature of the cornea and horizontal curvature of the cornea. I have two curvatures. 90 degree, 180 degree. Yes. So we say if the curvatures are vertical and horizontal, that means at 90 degree to each other, it is regular. But if the curvatures are different from each other, one is 90 but one is 170, they are not at 90 degree to each other, it is irregular. If it is regular astigmatism, then which curvature is more curved? If the vertical curvature is more curved, we call it with the rule. VW, everybody. Right? Alphabetically VW, or if you know the company Volkswagen, VW is the symbol for that. Okay, everybody? Against the rule means horizontal is more curved. Horizontal against the rule. And oblique means even though we have the meridians at 90 degree to each other, but they are not vertical and horizontal. They are oblique. Let's say this is 45 degree and this is 135 degree. You understand? The 90 degree angle is still maintained between both of them, but the meridians are not vertical and horizontal. Instead, they are oblique. Right, guys? Are we clear? Now, if we understand this classification, what is astigmatism? Let me go back to the question. When there is different refractory power in both the principal meridian, normally we say that the vertical power of the eye and the horizontal power of the eye are the same. But if let's say this is my vertical curvature, this is my horizontal curvature. But let's say I have a disease. I have a disease called keratoconus. In keratoconus, my vertical curvature increases because it becomes a cone. So I say my vertical curvature increases, horizontal curvature remains normal. Now what is going to occur, everybody? All the light rays that get refracted from the vertical curvature, yes, all the light rays that are getting refracted from the vertical curvature are going to get refracted with a higher curvature. Higher curvature means higher power. Higher power means all the light rays will converge in front of the retina. But all the light rays that were getting converged from the horizontal curvature, they are still getting converged with the normal power. Normal powers mean at the retina. So what do we see? That one image from one curvature is forming at the retina, the other image is forming in front of the retina because the power in both the principal meridian is different. And this is basically what is astigmatism. Am I crystal clear to everybody here? Yes? So, now if we see the refractive types of regular astigmatism, I hope I will be able to bring home my point much more. The first type, everybody, which is mentioned, simple myopic. It is the same thing that I have explained to you. On refraction, one curvature forming image on the retina, the other curvature forming image in front of the retina. Because one is forming in front, so we are saying one of the image is myopic, so we are calling it simple myopic astigmatism. Am I clear? Then I move on to the second example. Everybody, what do we see in the second example? We see one image is forming on the retina, but one image is forming behind the retina. That means one axis, one meridian is hypermetropic. So we are calling it simple hypermetropic astigmatism. Then if I move on to the third example, everybody, it is written compound myopic. Now let's see what is this. We say both the axes are myopic. Everybody, you see, the vertical as well as the horizontal axis, both are myopic. You must be saying if both are myopic, why it is not myopia? See, even though both the axes are myopic, the power of myopia is different in both the axes. Myopia in both the axes, but still different powers. That is why I am calling it compound myopic. Both the axes are myopic. Similarly, if I say, everybody, the fourth type, compound hypermetropic astigmatism, you will be able to see that both the axes are hypermetropic with different varying power. And if you are smart, everybody, you will understand the last variant yourself. The only variant left is one axis is myopic, the other axis is hypermetropic. So we are calling it mixed astigmatism. Myopia as well as hypermetropia as well as astigmatism in the same eye. Am I clear to everybody? So these are the 5 refractive types based on varying curvatures, either the vertical or the horizontal. Are we clear? Out of these, the most common to exist is compound myopic astigmatism. Compound myopic astigmatism. Okay? So now, after the types, we understand what is astigmatism. So what will be the patient's complaint, guys? What are the symptoms? So the first symptom is obviously, see, it is putting strain on my muscles. So I will have asthenopia. Secondly, usually what the patients will complain of is called as running together of letters. Running together of letters. That means if I show them an S, they will say that both the edges are running along with each other. They are merging kind of. So they will instead read it as an 8 probably. Are you getting my point, what I'm saying? So all the letters that I show on a Snellen chart, they run together the edges of it. They are not clear. Okay, running together of edges. And in cases of high astigmatism, the patient can have tilting of head. Tilting of head to make the axis, right? To make the axis. So tilting of head. These are the 3 symptoms. Usually, this is what the patient will complain when you are testing the Snellen's vision. Am I clear to everybody? Now, after we understand this much, what do we need to know? What is the treatment for astigmatism? Okay, everybody? So, what is the treatment for astigmatism? Let's see, everybody. Now, treatment. First of all, again, a lot of you must be wearing cylindrical spectacles also. So if you are wearing cylindrical spectacles, that means you are suffering from what, everybody? Astigmatism. Yes. Now the question comes, which cylindrical spectacles will you wear? Concave or convex? cylindrical concave or cylindrical convex? You know, yes, you understand? Based on the type of astigmatism, myopic astigmatism or hypermetropic astigmatism, you may need to wear concave or convex, right? So, based on refractive type of astigmatism. I hope there is no confusion in this. Okay. Now, apart from spectacles, what can be done, everybody? Surgeries can be done. If surgery is done, what is the surgery being done, everybody? The most commonly surgery which is done is called as astigmatic LASIK. LASIK done for astigmatism. What can also be done is LRI, limbal relaxing incisions. Very simple concept, limbal relaxing incisions. Whichever curvature is more curved, at the limbus, you give incisions so that when it heals, it flattens out that curvature. Okay, everybody? So at the limbus, you will give partial thickness incisions to flatten out the more curved axis. Then thirdly, there is something called as Rui procedure. This is done for post-keratoplasty astigmatism. If after keratoplasty, that is corneal transplantation, a patient lands up in astigmatism, high astigmatism, then you have to do this surgery. Apart from the surgeries, we can give contact lenses. Obviously, we can give contact lenses, but those contact lenses are specifically known as this, toric contact lenses. Please remember this word, toric contact lenses are used for the treatment of astigmatism. Toric lenses, toric contact lenses. Am I clear? If you have been able to understand astigmatism, myopia and hypermetropia, everybody, using everything that we have read about the spectacles, I'm going to discuss next a topic which is very important from our exam point of view, a hard topic which is being asked every year in NEET now. Let's move on to discussing some miscellaneous refractory conditions. So let's see the first miscellaneous refractory condition, guys. Anisoconia. So what is anisoconia? Anisoconia is when there is distortion of vision which leads to different size and / or shape of image between both eyes. Okay? So from one eye you see Amitabh Bachchan, from the other eye you see a Shah Rukh Khan. So size is different. From one eye you see a square, from the other eye you see a circle. So either the shape can be different or the size can be different, or both the shape and size. There is some kind of distortion of vision, anisoconia. Then the second condition that we want to list here is anisometropia. Anisometropia, I hope a lot of you have heard of. Anisometropia is when there is different refractory power between both eyes. Different refractory power between both eyes. Okay? One eye you are wearing a -2, or the other eye you are wearing a -3. That means you have different refractory powers in both the eyes, and that's why you are said to be anisometropic. But does this pose any problem to any of you? Almost everyone who wears a spectacle has slightly differing powers, but it does not cause any problem. Why? Because anisometropia is significant only if the difference between both the eyes is greater than 2.5 diopters. Okay? Now, why is that so? Let's understand. Let's take an example, guys. Let's say in the right eye you are wearing a +2, but in the left eye, let's say you are wearing a +6. Just an example, guys. Now, each diopter of lens, 1 diopter is equal to 2% magnification. Plus lens means convex lens. Convex lenses are magnifying lens. Each diopter will magnify your image by 2%. So in the right eye, there is 4% magnification. Whereas in the left eye, there is 12% magnification. So again, in one eye you are seeing a little small, in the other eye you are seeing a little large. If greater than 5% difference in image size between both the eyes, there is around a 8% difference here. Our brain is not able to fuse both the images. Grades of binocular single vision fusion. Yes? So what will occur, everybody? Diplopia. Okay? So because of the varying, everybody, magnification, there is diplopia, and that is why anisometropia will become significant only if greater than 2.5 diopter difference. Okay, everybody? Now, the next condition I am writing is emetropia. I hope you understand the meaning of this word emetropia. Let's say in the examination, my image comes, my photo comes, and they ask you, what is the refractory status of the above person? I am not wearing any spectacles. I am not wearing any contact lenses. I have not got a surgery done. That means my refractory power is absolutely normal. When the refractory power is normal, it is called as emetropia. Okay? I hope no confusion about this. Now, the last condition which I am discussing with you as a miscellaneous topic is aphakia. Aphakia, everybody knows, is absence of lens. A means absence, phakia means lens. Now, if you are wondering why am I discussing a condition of the lens as part of an optics, you have to understand that aphakia at last will lead to an optical problem. What will that be? That's my question to you. When there is absence of lens, aphakia, no lens in the eye, it will lead to a refractory error. Which refractory error? Think about it. Myopia, hypermetropia, astigmatism, what will it lead to? If you are smart, you are thinking right. Absence of lens means the power is less. The power of lens was 16 to 19. I have removed the lens. There is no lens, so the power of eye is lesser. When the power of eye is lesser, it leads to what, everybody? Hypermetropia. Yes or no? Yes or no? Yes. Power more myopia, power less hypermetropia. So aphakia is basically a cause of hypermetropia. Now, in aphakia, if you will see the pupil, the color of the pupil is said to be jet black. Normally, the pupil is black, but here, because the lens is also removed, it becomes more black, so called as jet black. Then, everybody, comes the concept of Purkinje images. Purkinje images. What are Purkinje images? Let's understand. If you don't know, I'm asking you a simple question. This a lot of us know. How many Purkinje images are normally seen? The answer is 4. The answer is 4. But what are Purkinje images? Let's try to understand. Let's say I throw light onto your eye. Yes? The light will first of all fall on cornea. Cornea is transparent, yes or no? Yes. So that means cornea is like a glass surface. A glass surface will reflect light. So on the cornea, you will be able to see a reflection of light. But if you will look closely, you will actually not see one reflection of light. You will see 4 reflections of light. Why? Let's understand this, everybody. My cornea has 2 surfaces, anterior surface, posterior surface. Light will reflect from both surfaces. Similarly, then there is a lens. Lens is also transparent, so lens is also glass-like surface. So if I look carefully, I will see 4 reflections of light. First reflection of light occurring from the anterior surface of the cornea. Second reflection of light occurring from the posterior surface of the cornea. Third, from the anterior surface of the lens. And fourth, from the posterior surface of the lens. So normally when I look at the eye, I see 4 Purkinje images, 4 reflections of light. The easiest question that they ask you is, what I have just said, what I have just drawn, each reflection of light comes from which part of the eye? So as is visible very easily, first comes from anterior surface of cornea. Second reflection of light comes from posterior surface of cornea. Then third comes from anterior surface of lens. And lastly, fourth comes from posterior surface of lens. There should be no confusion. Very simple concept, everybody. Now, one more question about Purkinje images. They will ask you which Purkinje image is inverted. See, an image can either be inverted or be erect. We are asking which image is inverted. So the fourth image is inverted. Why, if you want to ask me, it is very clear. See, the first surface convex to light, second surface convex to light, third surface convex to light. But the fourth surface for light is what, everybody? Concave. Yes, the fourth surface, the posterior surface of the cornea, when light is falling on it, is concave, and that is why an inverted image is seen. Am I clear? Now let's come back to aphakia. Normally we are saying there are 4 images, but in aphakia, how many Purkinje images will be seen? Aphakia means absence of lens. So neither the third image nor the fourth image. So that means how many images will be seen? Only 2 images. Am I clear to everybody? Number 1 and number 2. No confusion about this. Clear? Now, once we have aphakia, I can ask you, what is the treatment of aphakia? Aphakia means absence of lens. So what should be the treatment of choice? That you implant an IOL implantation. As simple as that. Or a person can wear contact lenses. Okay, just the usual, guys. Or lastly, you can wear some spectacles. Okay, but if you wear spectacles, you will have to wear convex spectacles, because it is at last hypermetropia. Yes or no? Convex spectacles of what power? The power of the lens was 16 to 19 diopter. Your spectacle needs to have that much of power, but it is impossible to make such a high powered spectacle because the lens keeps on becoming thicker and larger in size. So usually the patient is prescribed plus 10 diopter to plus 13 diopter. Okay, that's the usual prescription if spectacle has to be given. But such a high power spectacles comes with its own side effects. So side effects of a high powered spectacle. Very simple, guys. As already explained to you a little while back, 1 diopter is equal to 2% magnification. So if I'm wearing a 10 diopter or a 13 diopter spectacle, I will have the trouble of magnification reaching around 25%. One eye 25% magnification, other eye normal. Again, I will land up with diplopia, just like in anisometropia. I hope you understand this. Yes? The second important side effect of this spectacle is called as pin cushion defect. This is a spherical aberration. Pin cushion defect. Why is it called pin cushion defect? If this is how big your spectacle is, in the center you will be able to see clearly, but in the periphery you will be able to see everything stretched. Okay? Because of the high power, this is the phenomena which results. If you see, your vision becomes like a pin cushion, like a cushion that our mothers keep in our sofa or in our drawing room, everybody. Yes or no? With all those tassels at the end. Yes? So that is why it's called a pin cushion defect. And lastly, Jack-in-box phenomena, also known as roving ring scotoma. This is a prismatic aberration. What do I mean to say when I say prismatic aberration? See, because my lens is thick, this is the front surface. But because it is thick, if I see it from side, it has an edge also. So basically the light will enter from the front and will be able to go out from the side. So basically there will be 2 surfaces for refraction of light. Prism, like a prism, front surface, back surface, everybody. Yes, because of the thickness there is a side edge also. And that is why this prismatic aberration occurs, which is known as Jack-in-the-box phenomena. Am I crystal clear to everybody here? Yes. And that's it about my topic aphakia. Very simple and short. Questions are usually asked on the side effects of a high powered convex spectacle. Please remember that aphakia is a cause of hypermetropia.
Now let's see on screen a complete chart given to you as a synopsis, which is all the tests which are done to calculate your refractory error. Okay, everybody, this is an exhaustive table. If you know these names, if you know these tests, everybody, then you are starting from the basic and you are ending up refining the final refractory error. So first of all, let's see, everybody, what is refraction. As is written here, everybody, the procedure of determining and correcting refractory errors is known as refraction. All right, we are determining the refractory error, that what is the refractory error, and then we will be correcting it, everybody. Now, there are two main ways of doing this, everybody. One is objective refraction, one is subjective. As the name says, everybody, subjective means where we will be taking the input of the subject, that is the patient, everybody. But in objective refraction, the examiner is doing everything. We are not asking from any input from the patient, everybody. Yes, that is the first step we do, objective refraction. Objective refraction is known as retinoscopy. Now, retinoscopy can be done in two ways, manually or through automated machines, automated refractometers. We call them AR. If you ever go to an ophthalmologist these days, usually you will see everywhere ARs getting used, everybody. Manual retinoscopy is a very important tool to learn when we are doing post-graduation, everybody. We don't have an AR is not functioning, you don't have electricity, you have gone to do a camp everywhere. But if you know the principles of retinoscopy, if you know how to do retinoscopy, you can always and always do refraction, everybody. Okay? So, manual retinoscopy is done or can be done through any of the three instruments as we can see on the screen. The first is a reflecting mirror retinoscope. Simple mirror, everybody. You are holding this mirror. There is a bulb which is reflecting the light into the patient's eye. And that is how you are doing retinoscopy. The second is Priestley Smith retinoscope. The difference you see, it has two mirrors, everybody, in this. One is a plane mirror. And the second is a concave mirror. Okay, everybody. Now, the third instrument which we actually use clinically is a self-illuminated streak retinoscope, everybody. Self-illuminated because it has battery in it. Streak because the light that comes out through this instrument comes in the form of a single line or a streak, everybody. A vertical or a horizontal streak of light, everybody. Yes, that is what we are discussing, how to do self-illuminated streak retinoscopy and how to see the results of this, everybody. So let's start, everybody, retinoscopy. First of all, we should know that retinoscopy is also known as skiascopy, also known as shadow test. Retinoscopy is the most popular name, obviously, but the other names also we need to know. Okay. When we are doing an investigation, the first question that I ask or I will ask everybody is, what is the distance of examination? So we are saying the distance of examination may vary depending on the examiner's preference. But usually, commonly what we answer, what we use is the distance of examination is 1 meter. We are not talking about Snellen chart. Don't say 6 meter, guys. So the distance of examination is 1 meter. Now, what do we do in this, everybody? Method. Okay. So let us try to understand. We have an instrument which is a self-illuminated retinoscope. Okay. Now, let us assume that this is my retinoscope. I don't have a retinoscope, everybody. I don't use it. That's what I said. I use an AR. I know how to do it, but I don't use it. Okay. So let's say this is a self-illuminated retinoscope, everybody. I hold this in my hand and I keep it in front of one of my eye. If you have seen the video of direct ophthalmoscope, it is like the same, everybody. Yes. So I keep it in front of my one eye. Light, streak of light comes, enters the patient eyes, falls onto the patient's fundus. Okay. Fundus is red color, everybody. So what do we see, everybody? Through the pupil, we see a red colored shadow, or I can say a red colored reflex, everybody. Yes or no? You understand what I'm saying? Now, we move the instrument to the left or to the right, and we see the behavior of the red streak, everybody. The red streak can behave in three ways. Number one, the red streak moves with the movement. I move my instrument to the left, it moves to the left. I move to the right, it moves to the right. Second, everybody, it can move against the movement. I move to the left, the streak moves to the right. I move to the right, the streak moves to the left. Or third, everybody, when I'm doing it, everybody, movement, the streak does not move. Okay. So what we are doing is we are seeing the movement of the red reflex or the red streak in comparison to the movement of the retinoscopy that we are doing. And based on that, we are determining the refractory status of the eye. Okay. Let us first see an image, everybody. I hope you understand that the examiner is holding a retinoscope. This is a self-illuminating retinoscope, which is giving light into the patient's eye. And that is what the examiner is trying to do here. Retinoscopy. Now, if I say method, everybody, in the method we are saying the patient is asked to focus at a distant object. Why is this done, everybody? We already know accommodation, yes? So if the patient is focusing on a near object, accommodative power will come into effect, and at last the refraction you do will not be accurate, yes? So the patient is asked to focus at a distant object. Then light is shown in the patient's eye. And finally we are saying movement of red streak or red reflex is noted in comparison to movement of retinoscope. Okay, everybody. Now, this, as I said, can behave in three ways, which has been exemplified through photographs, everybody. So it can move against the motion, it can move with the motion, or it can be neutral. Neutral means no movement. Can I say neutral means no movement? If there is no movement, everybody, then we say the diagnosis is 1 diopter of myopia. If there is against movement, then we say greater than 1 diopter myopia. But if there is with motion, everybody, then the answer can be less than 1 diopter myopia or emetropia. As we saw a little while back, emetropia means, everybody, normal refractory power, or hypermetropia. Okay, everybody. So based on the direction of movement, this is how we are able to narrow down onto the refractory error. Okay. No movement, 1 diopter of myopia. Against movement, greater than 1 diopter of myopia. And if it is with the motion, we are saying it is less than 1 diopter of myopia or emetropia, or moving towards the plus side, that is hypermetropia. Okay. Now the question that some students are asking me or asking themselves is, sir, why is there 1 diopter of myopia even when there is no movement? Very good question. That is why we should know something called as the correction factors. See, when we are talking about optics, we are talking about a lot of things to do with the light rays, how they travel, everybody. Yes. So we have to take into account distances also. So we say correction factor number 1 is for distance of examination. So we say C1 is equal to 1 upon D. D is distance of examination. Okay, everybody. So that's the formula. So if you understand, everybody, when we are doing it from 1 meter, everybody, so example 1 meter, so correction 1 is equal to 1. Yes or no, everybody? Correction factor 1. 1 by 1 is 1, everybody. So 1 diopter of myopia is there because when we are doing it from 1 meter, actually we have to take into account the distance also, correct it. So there is no movement, the power should have been 0, but when we correct it, we get minus 1 diopter myopia. After we know the correction factor 1, everybody, what is the second correction factor? Second correction factor is for tonus allowance for cycloplegia. As we just now said, everybody, that the patient should be looking at a distant object because we do not want accommodation to play a role. So what is the better way to do it, everybody? The better way to do refraction is to abolish accommodation. How do you abolish accommodation, everybody? You abolish accommodation by doing cycloplegia. Okay, everybody? So when you are doing cycloplegia, there has to be some tonus allowance for the drug used, everybody. What is the tonus allowance, everybody? Atropine. The correction factor for atropine is 1. Home atropine. The correction factor for home atropine is 0.5, and for cyclopentolate, this is 0.75. Okay, everybody. So based on the cycloplegic agent used, everybody, you have to correct the retinoscopy finding. Now, we know the correction factor C1, C2. But another question comes into my mind. We are doing cycloplegia. So what is the cycloplegic drug of choice? So two questions, everybody. Drug of choice in children. For retinoscopy to dilate, cycloplegia, abolish the accommodation, what is the drug of choice in children? Yes, everybody. Yes, I know you know. Yes. Some of you are saying atropine. I will say 1% atropine. Eye ointment. Eye ointment has to be used in children specifically because it has longer retention time, everybody. Okay. So we know that the child is not going to blink out the eye drop. Okay. Secondly, what is the drug of choice in adults? Now, this is where a lot of students answer wrongly. A lot of students are saying, I know tropicamide, tropicacil, something like that. But please remember, tropicamide is not a cycloplegic. We don't want to dilate the pupil only. We are not talking about fundus examination. We are talking about refraction. We want to abolish the accommodation. So we want to have cycloplegia. Tropicamide does not have any cycloplegic effect. Yes? So the answer is 0.5% or 1% cyclopentolate eye drops. That is the drug of choice in adults. So guys, now that we know the basics of how to do retinoscopy and what we are doing through retinoscopy, everybody, let us understand a very important point. How do we actually prescribe spectacles from a retinoscopy finding? Okay. So that is my next very important topic, everybody. How to prescribe spectacles. Doing retinoscopy is only half the job, everybody. You need to know the maths after it. Yes. So let's say the given retinoscopy findings, I am writing as RF, okay, are like this. So see, we present them in this form. The vertical axis and the horizontal axis. Horizontal axis is 180 degree, vertical axis is 90 degree. Okay. So the given is -2 and let's say +1. Just an example. This is the given retinoscopy finding. Distance of examination is equal to 1 meter and cycloplegic used is atropine. So you are the examiner, you have found out that this is the retinoscopy finding, everybody. You have done it from 1 meter and the cycloplegic used is atropine. Now, you want to prescribe spectacles. So the first step in prescribing spectacles, everybody. So we are saying step 1. Step 1 is to calculate corrected retinoscopy findings. Now, how to calculate corrected retinoscopy findings? The answer is very simple. Retinoscopy findings minus correction factor 1 minus correction factor 2. That's the formula. This is equal to corrected retinoscopy finding. Okay, everybody? So this part is easy, I hope. If not, let's understand. So we have been given the retinoscopy finding, we have been given the distance of examination, which should be correction factor 1, and cycloplegic used, which should be correction factor 2. So let's see, everybody, what is our correction factor 1? Our correction factor 1 is 1 by D, which is equal to 1 by 1, which is equal to 1. For atropine, we just now saw that correction factor 2 will be equal to 1. Okay, everybody? Okay, so now let's see, everybody. What does our corrected RF become? The given RF was, not writing the axis this time, we had said -2, we had said +1 in the vertical and the horizontal axis respectively. Now we have to say -1, that is the C1, -1, that is the C2. Okay, everybody, I hope we are clear. Similarly, here we are writing -1, -1. Okay, everybody, no confusion till now. What does the corrected retinoscopy finding become, everybody? Let's see. So the corrected retinoscopy finding now becomes -2, -1, -1. Maths, -4. +1, -1 cancel each other. What is left? -1. Okay, everybody. So we change from -2 +1 to -4 -1. I hope you understand how it is changing, everybody. Yes or no? Am I clear to everybody? So this is my corrected retinoscopy finding. Step 1 done. Now from corrected retinoscopy finding, step 2 is prescribe spectacles. Okay, so how to prescribe spectacles from corrected retinoscopy finding. So this was my corrected retinoscopy finding. Okay, we had written -4, or we had found out -4 and -1. -4 at 90 degree and -1 at 180 degree. So to prescribe the spectacles, the first step is choose any axis as spherical. Okay, choose any axis as spherical, whatever you will feel. So let's say in this case I choose -1 as spherical. So I write -1 diopter sphere. Then the other axis becomes mark as X. So now I am marking the other axis as X. Step 2. Calculate cylinder, which is C, as X minus S. X minus S. So now what does my cylinder become in this case, everybody? What was X? -4. Minus -1. Okay, everybody? -4 plus 1 is equal to -3. So now my cylinder becomes -3 diopter cylinder. Okay. Step 3. Choose axis of cylinder 90 degree to X or same as spherical. So that means my axis now becomes, we had chosen spherical at 180 degree. 180 degree. Why is that so? Even though we are saying 180 degree, we have chosen as spherical, but still the axis of cylinder we are keeping as 180 degree, because the cylinder, whichever axis it is kept in, it always acts 90 degree to that. So if we keep the cylinder at 180 degree, everybody, then it will neutralize the refractory error at 90 degree, everybody. So what does my refractory error now become? My refractory error becomes -1 diopter sphere with -3 diopter cylinder at 180 degree. Okay, but now some of you are asking, what if we had chosen the other way around? Let us see, everybody. Let us choose the other way around. Again, let's write 90 degree, 180 degree, -4, -1. What if we had chosen this as our sphere and this as our X? Then let's see what the number would have become, everybody. Then the number would have become -4 diopter sphere. Okay, everybody, no confusion about this. It was -1 diopter sphere above, -4 diopter sphere with X minus S. X minus S now becomes -1 minus -4. -1 plus 4 is equal to +3. +3 diopter cylinder at the axis of S, that is 90 degree. Now if you are wondering which of the two corrections is correct, we will understand this through our next topic, everybody, that is how to read a spectacle prescription. Till now, we have been able to understand what is retinoscopy, how to prescribe a spectacle. Now, which spectacle out of the two to prescribe based on the same retinoscopy finding, and how to read a spectacle prescription. That's the next very, very, very important topic, everybody, and a very basic topic at that. Let's understand. So, how to read a spectacle prescription. Okay, now for this I will begin with the easiest thing. I will keep on giving you examples. Example number 1. Let us say that in one eye, we are talking about one eye, the power that you have been given is minus 2D spherical. Okay, which refractory error are you suffering from? That is the question here. So the answer here, everybody, is we focus on which type of refractory error, spherical or cylindrical. We already know that spherical means myopia or hypermetropia and cylindrical means astigmatism. We forget the power. The number does not matter. Whether it is 2 diopter or 3 diopter does not change the refractory error. Then we focus on the sign. So here we know that we have a minus sign, everybody, and we have a spherical power. Spherical can be myopia and hypermetropia. Myopia is minus, M for myopia, M for minus. Yes. So this becomes a simple case of myopia. I hope there is no confusion. Now, let's see example 2. In example 2, I say that the refractory error that has been prescribed to a patient is minus 1D CYL. So now instead of a spherical, everybody, the patient has been prescribed a cylindrical. Cylindrical means it has to be astigmatism. But again, it is which astigmatism? It is minus astigmatism. So minus astigmatism, we know the 5 types of astigmatism. So the minus astigmatism has to be myopic astigmatism. This is simple myopic astigmatism. Okay, everybody? Then, third example. In the third example, everybody, let us give this error. One eye only, everybody. Just like we saw just now, in the same eye there is spherical error as well as cylindrical error. How will you name it, everybody? So we have a cylinder, we have a sphere, but both are minus. This is also minus, this is also minus. That means we are talking about myopia. See, if we make it 2 parts, part 1. Part 1 is myopia, part 2 is simple myopic astigmatism. Yes or no? So if we combine both, we get compound myopic astigmatism. I hope you understand again what I am trying to say here. Yes. So this is the third refractory error. Now, fourth, everybody, very easy. You will find it now if you understood 1, 2, 3. I give you plus 0.75 DSPH. Now it should be very easy. Yes, I know it is very easy. It is spherical, sir. It is plus, sir. Yes, sir. It is hypermetropia. Yes. So this is hypermetropia. Then example 5, everybody. In example 5, we see, you know what we'll see. Yes, you know what we'll see. I know. See, if you're thinking you already know what I'm going to, I give you an example of. Yes. So now we are saying it is cylindrical and it is a plus cylinder. So a plus cylinder should mean, yes, simple hypermetropic astigmatism. Writing in short form HA, hypermetropic astigmatism. Moving on to the sixth example, everybody. Plus 1 diopter sphere with plus 0.75 diopter cylinder. Okay. Again, the same eye, everybody. We are talking about one eye, everybody. What is the answer here, everybody? Cylinder also, sphere also, both are plus. Yes? Yes, very good. So the answer is compound hypermetropic astigmatism. Yes or no, everybody? No confusion about this? Now, example 7. In this example, I say minus 4 diopter sphere with plus 3 diopter cylinder. Or let's say I say plus 4 diopter sphere with minus 3 diopter cylinder. What is this? What is this? You are saying mixed astigmatism. Yes, you are saying mixed astigmatism. You are saying why if you are saying that, sir, there is spherical, there is cylindrical. One of them is minus, one of them is plus. So one axis is myopic, one axis is hypermetropic. It has to be mixed astigmatism. If you are saying it is mixed astigmatism, you are absolutely wrong. You are absolutely wrong, everybody. Now let's see example 8. Okay. -1 diopter sphere with +3 diopter cylinder, or the other way around, +1 diopter sphere with -3 diopter cylinder. Now this, I will say, everybody, is mixed astigmatism. Why is this mixed astigmatism? This is mixed astigmatism because the sphere and cylinder are of opposite sign. One is minus, one is plus. Yes? Also, the important point to note, everybody, which was not present in example number 7, is that the power of cylinder is more than the power of sphere. That is a very important defining feature of mixed astigmatism. So if I say what are the 2 rules of mixed astigmatism, the first rule of mixed astigmatism is cylinder and sphere of opposite power, and secondly, the cylinder power is always greater than spherical power. Am I making myself very clear here, everybody? Only when such a case you get, that is when you call it mixed astigmatism. Example number 7, you can see, everybody, even though rule 1 is followed, the cylinder and the sphere power are opposite to each other, but the cylinder power is less than spherical power. That is why that is not a case of mixed astigmatism. I hope you understand here, everybody. No confusion about this. Yes, sirs? Okay. If we understand this much, let us move on to example number 9. Yes, a lot more is left. Yes, a lot more is left, everybody. Example number 9. We had said -1 diopter cylinder is simple myopic astigmatism. But cylinder needs to have axis. And because of axis, we know there are 2 types of astigmatism which we have read, with the rule astigmatism and against the rule astigmatism. So that means this is -1 diopter cylinder. Let's say the example is 180 degree. Now what is the refractory error? So I divide it into 2 parts. Part 1, part 2. Part 1 we know the answer of. Simple myopic astigmatism. Okay, everybody? Minus cylinder. But it is with the rule or against the rule? Is it with the rule or against the rule? Now let us answer the second part. Is it with the rule astigmatism or against the rule astigmatism? To answer that, everybody, I'll give you a very simple table. Okay? I write 180 degree. I write 90 degree. I write with the rule. I write against the rule. Then I write CVVC. Okay. Through a lot of calculations which you will do, you will arrive at last at this. That is what I want you to learn. The mnemonic becomes, everybody, yes, this becomes a mnemonic. With the rule I write with, against the rule I write against. So I remember it like with CV against VC. What does it mean, everybody? That let's say you are a very brilliant doctor, everybody, you have graduated from Harvard, Stanford, whatever, you are an MCH, you are a blah, 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 blah. So your CV, you understand that piece of paper that you take to take a job, everybody, yes? So your CV is very impressive. With that very impressive CV, you are going against the VC of your hospital, vice chairman or something like that. Okay, everybody? So with your CV, you are going against the VC. Okay? Now, what does CV mean here, everybody? So C for concave, V for convex, again convex, concave. Okay? All of us know that concave is which? Minus. Convex is which? Plus. So ultimately, this is what we are looking for when we are trying to answer a question. Okay, everybody? So let us see, everybody. We are talking about a minus at 180 degree. We are talking about a concave at 180 degrees. So I see 180 degree here, everybody. And I see concave here, everybody. When I see 180 degree and I see concave, I know we are talking about what, everybody? We are talking about with the rule astigmatism. So thus is becomes the answer simple myopic astigmatism with the rule. Are we clear about this? If not, let us see another example, everybody. Example number 10. I'm giving you an example and I hope you will be able to answer this for me. Minus 2.5 diopter sphere with minus 1 diopter cylinder at 90 degrees. Yes, some of you have already answered it, I know. Yes, some of you are geniuses. I am not, but other students are also not. If you are not a genius, everybody, it's all right. Hard work, everybody. You should be able to answer this question even then, everybody. Yes? Okay, let us take time. Okay, we are taking time. Let us take time. No issue. No issue. But I'm getting bored. So let me also solve it by then. This is spherical, this is cylindrical. Both are minus. So let us first do part 1. Which refractory error is this? So this is, yes, you are saying correctly, compound myopic astigmatism. Okay. Now the question is, it is against the rule or with the rule, everybody? So 90 degree concave with CV against VC. As soon as I say this, I know VC. Here comes my C here. So I know we are talking about concave minus at 90 degree. That means I am talking about against the rule, everybody. And that is what my answer is, against the rule. Okay. Even if you don't visualize this table, everybody, it is very quickly written down with CV against VC 180 90, and you can answer such a question if it comes in your exam, everybody. Okay. Now, the last example, everybody, and through that an important concept, example number 11. Okay. Let's say I have written minus 4 diopter sphere with plus 3 diopter cylinder at 90 degree. What is the refractory error the patient is suffering from? What is the refractory error the patient is suffering from? That's the question. Is it mixed astigmatism? See, this is similar to example number 7. Yes or no? We know that both the signs are opposite to each other, but the cylinder power is less than spherical power. That means it is not a case of mixed astigmatism. Are we clear about this much? If we are clear about this much, then how to answer such a question? In such a question, we have to use something which is called as simple transposition. What is simple transposition, everybody? We can convert this number into another number. Just like we saw when we were discussing how to prescribe spectacles, that for every given retinoscopy finding, there can be 2 sets of prescriptions given. Okay, everybody? So this is one set of prescription, but this is not any refractory error. So we have to transpose it into the other set of prescription, everybody. Simple transposition, I am writing new sphere is equal to old sphere plus old cylinder. New cylinder is equal to opposite sign of old cylinder, and new axis is equal to perpendicular to old axis. What do you mean by perpendicular to old axis? 180 becomes 90 and 90 becomes 180. Yes or no? Vertical becomes horizontal, horizontal becomes vertical. So let us apply this rule, everybody. What does the new sphere become? New sphere becomes old sphere plus old cylinder. Old sphere is minus 4 and old cylinder is plus 3. So minus 4 plus 3 becomes minus 1. Okay, everybody? Then what is the new cylinder? New cylinder is opposite sign of old cylinder. Old cylinder was plus 3. So the new cylinder becomes minus 3. Am I clear? New axis is perpendicular to old axis. Old axis is given as 90 degree. So the new axis becomes 180 degree. So what does the new transposed number become, everybody? The transposed number becomes minus 1 diopter sphere with minus 3 diopter cylinder at 180 degree. Okay. So from this we have reached this. Now can you answer which refractory error is this? Yes, now I know it is very simple. This is compound myopic astigmatism. Both are myopic and it is concave, minus at 180 degree. Minus at 180 degree is with the rule. And that becomes my answer. Am I making myself very clear here, everybody? Yes or no? So this is all that I can teach you, everybody, in how to prescribe a spectacle and how to diagnose the prescription. Yes or no? How to tell the spectacle prescription based on that which refractory error you are suffering from. So the first thing I want you to do is take out your prescription, everybody, people who are wearing spectacles, and see which refractory error you are suffering from. And please remember and revise, everybody, minus is equal to myopia. Yes. Plus is equal to hypermetropia. Cylinder is equal to astigmatism. Also remember the table, everybody, with CV against VC, 180 and 90. That's all you need to do, everybody. If you do this, you are good enough. Now I come back to everybody. This means when we had prescribed a spectacle, everybody, we had said that there are two sets of prescription. Yes or no? Which prescription is correct? That is what example 11 was. Yes or no? This is what the example 11 I had given you, everybody. Yes. And this is the transpose number, everybody. Let's transpose, everybody. You will be able to see. Plus 3 minus 4 becomes minus 1. Plus 3 becomes minus 3. 90 becomes 180, everybody. So this is compound myopic astigmatism with the rule. Okay, everybody, I hope you understand. Through example 11, I will trying to correlate how to read a spectacle and how to prescribe a spectacle for you, everybody. Yes? Now, if you know this, everybody, then you understand that the objective refraction has been done.
So now you need to do subjective refraction. You have found out the power minus 4 minus 1. Now you need to do what? Adjustment of refraction. Maybe the patient is not happy with the minus 4. Maybe the patient is happy with the minus 3.75. You have to adjust in small variants using trial and error method. What do you mean by trial and error method? I'll show you this photograph. As soon as I show you this photograph, I hope you understand a trial frame, everybody. This is called a trial frame. The patient is made to wear a trial frame in which I will occlude one eye. You will see this eye is occluded. Occluded left eye. The right eye is getting tested, everybody. Yes. In the right eye, will keep a disc of minus 4. I'll ask the patient to read the Snellen chart. Then I will adjust it by 0.25, 0.5, everybody. Yes. So trial and error, subjective. It will be based on the patient's response, right? Similarly, everybody, the same thing can be done by fogging technique. What is that? I'm not going into the detail. Just remember the name. After you have adjusted the refraction, everybody, still the patient comes to you after one day saying, no, I'm not happy. I have some kind of inkling. That means I need to refine the error. Refinement of refraction, refinement of cylinder, refinement of sphere. Refinement of cylinder is done by using Jackson's cross cylinder test or astigmatic fan test. I will discuss a little bit about this. And refinement of sphere is done by duochrome test and pinhole testing. Okay. So let's see first of all Jackson's cross cylinder test. This is the instrument which is a Jackson's cross cylinder. Okay, everybody? This is a lens which is made up of a minus 0.5 diopter sphere with a plus 1 diopter cylinder. So we say it is a sphero-cylindrical lens. Through the use of this, you are able to calculate any small variation in the power of the cylinder that you may have given wrongly. Okay. Just remember the image of the instrument and remember this, everybody, that this is a minus 0.5 diopter sphere with a plus 1 cylinder. Again, not going into the details of the optics of how it functions. The second test, everybody, I'll just write the name so that you remember this photograph, Jackson's cross cylinder. Okay. Now, the second test that we said can be used for refinement of cylinder was astigmatic fan test. Right, guys? Astigmatic fan test. You understand fan, everybody? You must have seen it in movies, and when you And if you have gone to a hill station, everybody, or in movies, actresses keep it, which can be opened like this, which can be closed like this. Okay, yes. So astigmatic fan, which can be used to do manual air on yourself. So this basically is showing you all lines at all the axes, 90, 120, 150, 180, all the axes. You ask the patient to look at this fan of lines, and you ask the patient if any one of the lines is more clearly visible or darker. If the patient says no, all the lines are equal in intensity and everything, then there is no problem of axis. But if the patient says, I can see the 70-degree line much more clearer, that means the axis you have given versus the axis of the patient, there is some refinement which needs to take place. Am I clear to everybody? So that is your astigmatic fan test. Very crude, very basic test. Done? Now, cylinder refined. Now let's refine the sphere. So sphere is refined by this test. This is called as duochrome test. Duochrome means two colors. As you can see, this is usually present below the Snellen's chart, everybody. Yes, there are letters written on a green color background and letters written on a red color background. We ask the patient to read the letters on both the colors, green as well as red color. If the patient says letters on green background are more clear, this indicates that there is residual hypermetropia. Okay? But if the patient says that letters on red background more clear, there will be the opposite. There will be residual myopia. Am I clear to everybody? But if both the letters are equally clearly visible, there is no residual myopia or hypermetropia. Spherical refinement. Myopia and hypermetropia, not about the cylinder now, everybody. Okay? I remember it by MR. Myopia means red will be more clear. MR. That's how I remember it. Okay, everybody? MR. MR. No confusion about this? Done? Now, the other test was what, everybody? Pinhole test. So I hope as soon as I show you this image, very clearly visible that this is a pinhole, everybody. Yes, pinhole, everybody. In the center of the disc, there is a small hole. What is the size of pinhole? If you are used to creating a pinhole in a piece of paper by your pen, you are creating it wrongly. Your size is not constant. Yes, the size of the pinhole has to be 1 mm, 1 millimeter. Please remember this. Now, what is the use of the pinhole, everybody? Use of the pinhole is it can find out, it can refine any residual spherical error. Okay, how? Everybody, let's see. So, keep pinhole in front of patient. Okay, two things can occur when you keep a pinhole in front of the patient. Vision improves or vision decreases. Now the patient is looking through the small tiny hole, and now you are asking whether you are able to see clearer or not. If the patient says on keeping a pinhole that yes, I am able to see clearer, if the vision improves, then there is a residual refractory error up to 4 diopters. Up to 4 diopters, there will be a refractory error. It can even be only used to simply diagnose whether the patient has a refractory error or not based on this fundamental, apart from refinement. But if the vision decreases, the patient has a macular pathology. Okay? Now you must be thinking why. Let's understand why. Let's understand why. Everybody, just drawing a cut section again. Normally, the light rays that are going in are like this. The central light ray does not need any convergence. The convergence which is taking place is actually in the peripheral light rays. Yes? Let's say this is a case of myopia. The central light is going straight. It is straight. It is going straight. The peripheral light rays are getting converged, and due to the myopia, they are forming an image in front of the retina. That is why the patient is having some problem. Okay? I now place a pinhole in front of the eye. Pinhole will cover all the peripheral light rays. Yes or no? Can I say? Only a 1 millimeter hole in the center. Yes? So basically your pinhole will allow only the central light ray to go. The central light ray was not getting refracted at all. So whether the power of the eye is more or less, it does not matter. So if there is any residual refractory error, because now only the central light ray is going, all the peripheral light rays are now being cut, the vision will improve. You understand this point? But what if there was a macular pathology, everybody? Now because only the central light ray is going, everybody, and there is a pathology at the macula, the vision will actually decrease. The peripheral vision will now not be able to support the loss of or problem of central vision. Am I crystal clear to everybody? This is how the pinhole works for diagnosis of a refractory error. Or as I can say, use number 2, everybody. Use number 1, are we clear? Refinement of any residual spherical error. Or I can say use number 2, diagnosis of refractory error up to 4 diopters. Or if I say from the same concept, use number 3, everybody, diagnosis of macular disease. Am I crystal clear to everybody here? No confusion? What are the other uses of pinhole apart from this? Number 4. Pinholes can be used as LVAs. LVAs means low vision aids. This is specifically a use of multiple pinholes. Multiple pinhole basically means a disc having lots of 1 mm holes. So there are lots of holes, everybody. Instead of a single 1 mm hole, there are lots of 1 mm holes. So we call that instrument or device as multiple pinhole. Then lastly, it can be used for 2-point discrimination test. This uses a 2-pin hole instrument. A pinhole which has 2 holes in it. Okay, everybody? What is this doing, everybody? Only 2 rays of light are going from 2 different points. If those points are visible separately, that means 2-point discrimination is present. But if those 2 points are visible singly, that means resolution is not there. Minimum resolution is not there. 2-point discrimination test. Am I clear to everybody? So these are certain other uses of pinhole apart from the main use that we have discussed here. Okay, everybody? So we have refined the cylinder through Jackson's cross cylinder and astigmatic fan test. We have refined the sphere through duochrome test and pinhole test. Even after that, everybody, even after that, when I ask the patient to see, the patient says, when I was looking from one eye, I was clear. When I was looking from other eye, I was clear. But once you are asking me to see binocularly, I see some problem. That is when we need to do binocular balancing. Binocular balancing, everybody, is done by test duochrome with fogging and prism dissociation method. Very rarely done, nobody does this, everybody, not going into the detail, just remember the names of these tests. This is a beautiful chart for you, everybody, on the screen, which explains you all the important tests, everybody, leading to the prescription of a spectacle, right? So this is your cohesive knowledge, and then you can just work on it a little more by the explanations that have been given to you. Right, guys? So that's about my part 4, everybody, of optics, how to calculate or how to prescribe the spectacle. So if you have seen the flow, we have completed our chapter on optics. I will just state 1 or 2 simple more facts relating to optics and 1 simple condition. Emmetropization. When I say this word, what does it mean? It means that a newborn has plus 2 diopter to plus 3 diopter hypermetropia as eye is small. Yes, at birth the eye is small. So the patient or the newborn, not the patient, the newborn is supposed to have hypermetropia. This hypermetropia will slowly reduce and the child will become emetropic. Achieves emetropia by 7 years of age. Okay, am I clear to everybody? So 2 questions here for you. So that is basically the 2 questions on emetropization. Similarly, if I just mention a fact regarding accommodation to you, I will say accommodation is maximum in children. Okay, that is why we have to use a strong cycloplegic in calculation of refractory error, atropine, everybody, all of us know that. There should be no confusion about that. Am I clear? Accommodation is least in old age. We already know this, that is why presbyopia occurs. Apart from this, accommodation has been covered completely in the chapter on basic anatomy of eye. I hope you have read it from there, you have been able to understand it. Lastly, just mentioning one word or one condition, you can say amaurosis related to optics. What is amaurosis? Amaurosis is complete loss of vision. Complete loss of vision, which may be unilateral or bilateral, without any findings, or I can say signs. When you examine the eye, everybody, there is no sign, cornea, lens, vitreous, retina, everything is absolutely normal, but still the patient is completely blind from either one eye or the other eye. That is called as amaurosis. Am I clear? Now, causes of bilateral amaurosis. Number 1, everybody, acute nephritis. And number 2, uremia. Number 2, uremia. In uremia, there is bilateral amaurosis, but pupil light reaction is absolutely normal. When there is bilateral amaurosis, why is pupil functioning normally? That's the question. Aren't the optic nerves damaged? No, they are not. Uremia, toxins act on higher visual centers. Okay, everybody? So the optic nerve and all the pathways completely left. So the pupil functions normally. Optic nerve, optic chiasma, optic tract, pretectal nucleus. Pupil is able to react to light. But the patient is bilaterally blind. This is the small thing that is asked to you in your MCQ. So please remember this. The word amaurosis is specifically due to uremia. Right, guys? Done? So these are just simple facts about optics. I hope you have been able to understand optics. I hope you have been able to understand the story of how to record a vision. Then if the vision is normal, what is the normal optics? Then if the vision is abnormal, what are the refractory errors? Spherical and the cylindrical refractory error. Then mainly the last part of how to calculate the refractory error and how to diagnose a refractory error or name a refractory error based on the spectacle prescription which is given to all of you. Okay, this is the minimum amount required for optics, everybody. As an ophthalmologist, the fundamental of giving a vision back to a patient is the most important. We don't want to do a surgery. We don't want to treat the patient. We want to do simple stuff. We just want to use our convex and concave lens. That brings me to the last small point to finish the optics chapter. How to differentiate between a convex lens and a convex. How to differentiate between a convex lens and a concave lens. Very simple, fundamental, but students don't know this. Convex lens, when you look through it, there will be magnification. Concave lens, when you look through it, there will be minimification. Okay? Concave is minus, image size becomes smaller. Concave is plus, image size becomes bigger. Secondly, if you look through a convex lens and move the lens. Image moves in opposite direction. I hope you understand what I'm saying. If I'm holding a lens in my hand, convex lens, and I'm looking through it, I move it up, everything that is visible to me will move down. Okay, everybody? Whereas, in case of concave lens, image moves in same direction. Okay? On holding through a concave lens, image moves in the same direction. You move the concave lens up, everything that you see will move up along with it. Am I clear to everybody? Then, if you ask me what are the uses of convex lens, you already know. It is used in hypermetropia. You already know it is used in aphakia. You should already know that it is used in presbyopia. It is also used in treatment of accommodative esotropia, accommodative squint, which occurs due to hypermetropia. It is used in our instruments which are ophthalmoscopes. Okay? So these are all the important uses of convex lens. Concave lens is used for the treatment of myopia. Concave lens is used as ruby lens, minus 58.6 diopter lens to visualize fundus. Okay, guys? These are the only two important uses of concave lens. Convex lens is much more used because of its magnifying power. Concave lens, limited use. Right, guys? I hope you will be able to differentiate between the two lenses. Specifically, if a third year is going for a Viva, everybody, this is a question. And even such questions can be asked as MCQs, everybody. All of the following are true, except question. With this, I finished the chapter of my optics. I hope you are able to learn. I hope you are able to understand. Very easy chapter. Gives you 2 questions in it at least.